So friends, after discussing the disorders of hypertrophy, let us now discuss the disorders of atrophy. The first disorder that we have to discuss in this is atrophic rhinosinusitis, commonly known as angina. Now this disease, atrophic rhinosinusitis, is caused by Klebsiella anginae. Okay, remember Klebsiella anginae is also sometimes called as Perez bacillus. Okay, now this disease, atrophic rhinosinusitis, is generally seen in females 20 to 30 years age group. So this is generally seen in young females. Anything else? Low socioeconomic status. Now when I say low socioeconomic status, it can mean a lot of things. It can imply a lot of things. What? Number one, patient may be having poor nutrition. Okay, so patient has poor nutrition, and poor nutrition may mean patient has iron deficiency. Patient may also have multivitamin deficiency, especially vitamin D deficiency. Okay, so multivitamin, but especially vitamin D deficiency. Right? It may also imply, you see, the low socioeconomic status may also imply poor hygiene. And we know that patient has Klebsiella anginae infection, and that's a result of poor hygiene. I also said that patient is a female especially, and that to a young female. So there may be some hormonal causes also, okay, that may lead to atrophic rhinitis. Similarly, we may also sometimes have some hereditary causes that may lead to atrophic rhinosinusitis. All right. Now, what happens in atrophic rhinosinusitis? There is an infection by Klebsiella. Now, because of this infection, we know that the nasal mucosa is lined by pseudostratified ciliated columnar epithelium. This epithelium starts undergoing atrophy. It starts dying. And when it dies, it is replaced by stratified squamous epithelium. Okay, now remember, the pseudostratified ciliated columnar epithelium is a thick epithelium, whereas the stratified squamous epithelium is a thin epithelium. So what will happen? That will lead to increase in airway. The middle turbinate, the inferior turbinate, the nasal mucosa, they will all undergo atrophy. They will all shrink in size. So the airway increases. Okay, this airway increases. That means the airflow increases. But remember, the pseudostratified ciliated columnar epithelium has the goblet cells. These goblet cells produce mucus. The mucus keeps the mucosa moist. Right? Now, the epithelium is gone. The goblet cells have also gone. They have decreased. So what will happen? Mucus production has decreased. Okay, now you see airflow is increased, mucus production has decreased. What will it lead to? It will lead to dryness. Right? Patient has dryness. Now what will happen because of this dryness? This dryness will cause crust formation in the nose. Right? Patient will have excessive crusting in the nose, excessive crust formation. And what will this crust do? It will cause nasal obstruction. Right? So how will the patient present to you? So remember, the patient presents to you with bilateral nasal obstruction. So remember, despite the fact that patient has large roomy nasal cavity, the patient main complaint, the chief complaint will be bilateral nasal obstruction. So remember, it is bilateral. The disease is bilateral. Right? Okay. And this obstruction is why? It is because of excessive crust formation in the nose. Excessive crusting in the nose. Any other complaint with the patient? These crusts are infected. We know they are infected by Klebsiella anginae. Now, because of that, patient will have a foul smell. Previously, this foul smell was known as angina, so therefore this disease was also named as angina. Right? Okay, now you see these crusts, they are blocking the nasal cavity. Patient is not able to breathe, the air is not going in. Okay, now because of that, the air is also not able to reach the olfactory fossa, they are blocked. So patient will have anosmia. Right? So remember, this patient also have anosmia. But I'll say that this anosmia is good for patient. Why this is good for patient? Why? Why this is good for patient? Because patient is having a foul smell. Everybody around the patient is having that foul smell. But the patient is not suffering from that foul smell. Okay, patient herself is spared the sufferings of that foul smell from this disease. So this is known as merciful anosmia. Okay, right? So this is how the patient will present: bilateral nasal obstruction, foul smell and angina, and merciful anosmia. Right? Okay, what will you find on examination? You will see a photograph like this. You'll see large roomy cavity which is filled with foul smelling crusts. Okay, what will you do for this patient? You see, patient has three problems: obstruction, foul smell, and anosmia. All the three problems are caused by these crusts. Okay, crusts are causing obstruction, they are infectant, causing smell, and they are causing anosmia. So what we will do? Our first aim is to remove these crusts. Okay, so treatment, we will do medical treatment. So what is there in the medical treatment? We have to first remove the crust. How we will remove the crust? We'll remove the crust with the help of alkaline nasal douching. Douching means washing the nasal cavity. Okay, with a alkaline solution. Now, why alkaline? Why not acidic? Why not neutral? Why alkaline? How do we make it alkaline? We make it alkaline with the help of sodium chloride. We put in sodium bicarbonate and we put in sodium biborate. Okay, so sodium chloride, sodium bicarbonate, sodium biborate. We put all these three to make the solution alkaline. Now, why do we use alkaline solution? You see, alkaline solution, number one, it will make these crusts soft. So it will soften the crust. So these crusts will be broken, they will be softened, so they will come out without any pain and bleeding. Okay, so these can be removed by douching itself. They will come out without pain or bleeding. Number two, remember Klebsiella. So remember the microbiology. This Klebsiella, it grows in acidic environment. Okay, so now what we are doing? We are changing this environment from acidic to alkaline and we are stopping the growth of Klebsiella. Right? Okay, so that was number one, first aim, to remove the crust. What do you want to do next? What is your second aim? You want to prevent the reformation of these crusts. How can you prevent the reformation? You will put in 25% glucose in glycerin. What is the role of glycerin over here? You see, this glycerin over here, this is a hygroscopic agent. So what will this hygroscopic agent do? It will absorb water. From the air, it will absorb water. And this water will moisturize the mucosa. It will keep the mucosa moist. So what will this glycerin do? This glycerin will prevents dryness. Okay. Now, why do we use glucose over here? See, the glucose will go inside the columnar cells and it will give them nourishment. So glucose is for nourishment, and what will happen because of that? Because of this nourishment, these columnar cells, they will sustain for a longer period. They will not die. Okay, and they will not be replaced by squamous epithelium. So you're preventing fresh conversion of columnar epithelium to squamous epithelium. Okay, so glucose is for nourishment. Right, now what else can we give to this patient? You see, this is a bacterial infection. We can of course give antibiotics to treat the infection. Okay, now remember, this patient had multivitamin deficiency, iron deficiency, remember, low socioeconomic status. So we also need to give vitamin D supplements, iron supplement to this patient. Okay, now one more thing that we can advise to this patient is estrogen nasal spray. Okay, what is the role of estrogen over here? Now before I tell you that, what is the role of estrogen in the uterine cycle, in the menstrual cycle? So remember, the estrogen is there in the proliferative phase. What happens in the proliferative phase? There is a proliferation of the uterine mucosa because of the estrogen. There is a hypertrophy. Proliferation means hypertrophy, increase in size. Now why the mucosa increases? What does the estrogen actually do? It increases blood supply. Okay, it increases blood supply of the uterine mucosa. How does it increase the blood supply? By causing dilatation of the existing blood vessels. Okay, so it dilates them. Anything else? It causes new angiogenesis. So new blood vessel formation, right? And this leads to proliferation. Now what has happened over here in atrophic rhinitis? The patient mucosa has undergone atrophy. We want it to undergo hypertrophy, to proliferate, to increase in size, and we need blood supply for that. So we can give estrogen nasal spray to the patient. Okay, now let's say we have given all this medical treatment, yet the patient is not responding. Why the patient is not responding? We have to ask this question, why? You see, sometimes patient of atrophic rhinitis presents to us very late. And when they present to us very late, they have already undergone a cycle, the vicious cycle. Now what is this vicious cycle? You see, the patient nasal mucosa is pseudostratified ciliated columnar epithelium, but now it has been replaced by stratified squamous epithelium. If a lot of conversion has taken place, this leads to increase in airflow. Okay, so a lot of increase in airflow because a lot of atrophy, and that leads to more dryness, and more the dryness means it will further kill the remaining columnar cells, and this cycle will keep on going. So you're giving all the medical treatment, patient is not responding, patient is having relapses because there is a lot of dryness, there is a lot of atrophy. So how can we break this cycle? Now we can break this cycle by one simple way, by stopping the airflow. Okay, how can we stop the airflow? We can stop the airflow by doing Young's operation. So what do we do in Young's operation? We close one side nasal cavity for 6 months. Okay, after 6 months we open it up, we close the other side for next 6 months. So what is the main philosophy behind it? The main philosophy is that you have given all the medical treatment. Now when you close the nasal cavity, the airflow stops, the dryness stops. So the columnar cells re-establishes itself on the nasal cavity. Okay, so it comes back, right? After 6 months, you open it up, you can close the next one for next 6 months. Now, instead of doing Young's operation, we can also do modified Young's operation. So what do we do in modified Young's operation? We close both the nasal cavities at the same time. So how will the patient breathe if we close both the nasal cavities? We keep a small opening in the center of each nasal cavity. You see over here, in both these, we keep a small opening of approximately 2 to 3 millimeter size. Through this the patient can breathe. So you can close both of them simultaneously, but this is a partial closure. Modified Young's operation. Now remember, it's not necessary to completely close the nasal cavity. We can achieve the same thing by decreasing the airflow. Okay, right? No, for that, nowadays we also have some non-surgical treatments. So before I go to the non-surgical treatments, let's discuss MCQs. Young's operation is done in. Now this question was asked in December, FMG, June FMG, and JIPMER November 17. Okay, so Young's operation is done in. Answer is atrophic rhinitis. Straightforward question. Next question. Partial closure of nose is done in which condition? Again, straightforward answer is atrophic rhinitis, and this is a recent question asked in NEET PG January 2020. So you can see that this question is a favorite question of examiners. It is being repeated multiple times. Okay, now instead of doing the surgery, we can also do the non-surgical method. What is that? We can inject Teflon paste. Now where will we inject Teflon paste? Answer is internal nasal wall. Remember, we studied the internal nasal wall, and this wall is formed between the lower end of upper lateral cartilage and the septum and inferior turbinate. Okay, so you can see over here, lower end of upper lateral cartilage, the nasal septum, and this is the inferior turbinate. So in between them we have this area, and this is the narrowest part of the nasal airway. 50% of nasal airway resistance is over here. So what we can do is we can inject the Teflon, make it further narrower. So we can further decrease the airflow just by injecting some Teflon over here. Okay, so this is the best point to inject it so as to decrease the airflow. Okay, other than this Teflon injection, or other than doing Young's operation, some people have also tried placing celastic sheet below the mucosa, but that is also a surgical procedure, right? Okay, remember what we will never do. That's also an important question. What we will never do in atrophic rhinosinusitis is turbinectomy. So turbinectomy means cutting and removing the turbinates. So when you cut and remove, you increase the nasal cavity size. Okay, and turbinoplasty. Now turbinoplasty generally means decreasing the size of the turbinates. So you don't cut and remove them completely, but you decrease the size, and again you will not decrease the size of the turbinates. Okay, so these surgeries you will not do, right? Okay, next let's come to rhinoscleroma. So this disease, rhinoscleroma, it is caused by Klebsiella rhinoscleromatis, also known as fish bacillus. Okay, this disease, rhinoscleroma, generally consists of 3 stages. Number 1 stage is stage of atrophy. Okay, now this stage of atrophy is similar to atrophic rhinitis, and that we have just discussed previously. Okay, it is exactly same. Stage 2 is stage of granuloma formation. Now there is formation of granulomas in the nose. These granulomas, what will they do? They will block the nasal cavity. Okay, patient will have complaint of nasal obstruction. Right? They block the nasal cavity. How will we make a diagnosis? To make a diagnosis, what we have to do? We have to do a biopsy. Okay, and we have to send this biopsy for histopathological examination, right? And what we will see in biopsy and histopathological examination, we will see Mikulicz cells. So you see over here, we have these cells with lot of cytoplasm. Okay, so big cells with lot of cytoplasm known as Mikulicz cells, and we have these dense eosinophilic bodies. These are known as Russell bodies. Okay, so we have Mikulicz cell and Russell bodies. When they are present together, they are pathognomic for rhinoscleroma. Okay, so they have to be present together so as to call it as rhinoscleroma. Okay, so remember that this question has been asked. Mikulicz cells and Russell bodies are seen in FMG June 18, and now you know the answer is rhinoscleroma. Right? Okay, so remember, biopsy followed by histopathological examination. This is the investigation of choice. Okay, so this is the investigation of choice for rhinoscleroma. All right, this will help you reach a definitive diagnosis. Okay, what will be the third stage? The third stage is stage of sclerosis or fibrosis or cicatrization. These granulomas, they start healing. So when they start healing, they undergo sclerosis or fibrosis or scar formation, cicatrization. Now when they undergo sclerosis or fibrosis, they become hard. The entire nose starts becoming hard. Okay, it gives a feeling like a wood. It's hard as a wood. So this is known as woody nose. Okay, the nose become hard like wood, known as woody nose. This condition was first described, all these three stages, they were first described by Dr. von Hebra. So with respect to his name, this disease has also been named as Hebra nose. Right? The nose is protruding forward. Okay, you can see over here, the nose is protruding forward. This is therefore also known as tapir nose. Looks like the nose of animal tapir, so it is also been named as tapir nose. Right? So remember, woody nose, Hebra nose, tapir nose, all these three are names which have been used in the past for rhinoscleroma. Right? Okay, now over here an MCQ question. What is the MCQ question? You see, if you get a question, woody induration, in rhinoscleroma is initially seen in which stage? So there are two things. There are two hints to your answer. First thing is, the examiner is not asking about woody nose. He is asking about induration. So induration means when you touch the nose, when you try to feel it, you will see that it is hard. It's not completely woody, but it is hard when you try to move it. And second thing is initially. So examiner does not want you to tell him about a completely woody nose when the induration initially starts, and that starts in the stage of granuloma formation. Okay, so the answer to this question is in the stage of granuloma formation. Right? So initial startup is in the granuloma formation, but complete woody nose is formed in stage 3, that is stage of sclerosis or fibrosis or cicatrization. Don't confuse the two answers. Right? Now, what treatment will you advise for rhinoscleroma? Yes, now there are two problems. There is an infection. Right? There's infection by Klebsiella rhinoscleromatis. So to treat that infection, we have to give antibiotics. So what is the drug of choice? The drug of choice over here is rifampicin. Now remember, for this disease, we have previously used other antibiotics, such as, for example, I will give you one example. We have used streptomycin plus tetracycline. Okay, now streptomycin plus tetracycline was used earlier, but rifampicin nowadays has more efficacy with lesser side effects. So rifampicin has now become the drug of choice. Right? Okay. Remember, this is the drug of choice. Patient has presented to you with complaint of nasal obstruction. So unless you treat the obstruction, his treatment is not complete. Remember, if you give only rifampicin, these granulomas will become hard and they will block the nasal cavity. So you have to remove the granulomas. So if somebody asks me treatment of choice, then I will say my answer is laser excision of granulomas. Okay, these granulomas they bleed. So you have to do an excision. It's better that you do with laser. Okay, and when you do it with laser, even then the base of these granulomas, they will bleed. Okay, so we will also do electrocautery of base. Okay, so as to stop the bleeding, we will do electrocautery of the base electrocautery. This is the treatment of choice. Remember, the drug of choice and the treatment of choice are different. Don't get confused in the exam. Right? Okay, let's go to the next condition known as rhinosporidiosis. This condition, rhinosporidiosis, is caused by Rhinosporidium seaberry. Now the first question, very important question, asked multiple times, what is this Rhinosporidium seaberry? This Rhinosporidium seaberry is now an aquatic protozoa. Okay, this is as per the 8th edition of Scott Brown. Right? This is an aquatic protozoa. Now you see, the Rhinosporidium seaberry has a very interesting history. Why? When this organism was initially discovered, it grew like a septate fungi. So it was taken as a fungus, a septate fungus, okay? Higher group of fungus. Now, when it was studied in detail, it was found that the life cycle of this is not like a fungi. It may look like a fungi, but it is not a fungi. So what was done? This organism was taken out of fungus. Okay, and it was placed under mesomycetozoa. Okay, right? Now later on it was discovered that on the genetic studies, the DNA of this organism is almost, I'm saying the word almost, okay, is almost similar to a lower aquatic fungi. Okay, right? It is almost similar to lower aquatic fungi. So some studies try to place it back into fungi, that to a lower aquatic fungi. Okay, remember earlier it was in septate, higher fungi, that was proved to be wrong because the life cycle was not same to fungi. So it was placed in the protozoa, special protozoa group, that's known as atypical protozoa group, known as mesomycetozoa. Okay, some studies showed that the DNA is almost similar to aquatic fungi. So it was taken out from their place in aquatic fungi. Once again back. Okay, but now it has been proved that its DNA is 100% similar to aquatic protozoa. Okay, so now it is an aquatic protozoa. It is no more a fungi. Right? So please remember this thing. This question is asked again and again. It is a aquatic protozoa now. It is no longer considered as a fungi. Okay, so it has been multiple times shuffled, but now the genetic study has been done and it has shown that it is 100% similar to an aquatic protozoa. Right? Now where is this disease found? This disease is found only in a few countries, few places. Which places? Southern coastal India. Okay, which coast? Our eastern coast. What is there in the eastern coast? We have Orissa, we have West Bengal, we have Andhra, we have Tamil Nadu. What is there near to them? We have Sri Lanka and we have Bangladesh. Okay, these are the only countries, these are the only places where we have this disease, rhinosporidiosis. Right? Now remember, the rhinosporidiosis is generally found in rural areas. Why rural areas? Areas where people take bath in a pond. Okay, now remember this disease, this organism, Rhinosporidium seaberry. The human beings are not in the life cycle. Okay, so what happens when you take bath in a pond, especially a dip bath, when you dip your head into the water, what will happen? This organism is in the cattle dung. Okay, so if the animals have also taken bath in the pond, the organism goes into the water and from there it infects the human beings. Human beings are accidental hosts. So what are we? We are accidental hosts. We are not the primary or the secondary or the tertiary host. We do not come in the life cycle of rhinosporidiosis. Okay, we are accidental hosts. Right? Okay. How will it present? This rhinosporidiosis, as you can see in the diagram, it forms this red, leafy, fragile granulomas. Okay, as you can see this, fragile, red, leafy granulomas with, you can see some yellow spots over it, and they look like strawberry granuloma. Okay, so they have also been named as strawberry granuloma. When you will cut them, they might bleed. Okay, how will you make a diagnosis? Diagnosis, once again, you have to take a biopsy. Now, when you take a biopsy, you will see multiple thick-walled sporangia. So, as I said, it looks like a fungus. Okay, but it is not a fungus. What is it? Now, it is proven to be an aquatic protozoa. Right? Okay, treatment. Now, treatment, we have two drugs. Number one, we have amphotericin B. This is a antifungal drug. And number two, we have Dapsone. Both these drugs have been used for the treatment of this organism. But remember, now we have proven it's a protozoa. So if somebody asks you which is the better answer out of these, I will say that you can mark the answer as Dapsone. Okay, that you can mark it as a better drug because it is a protozoa, right? But remember this thing, that if somebody asks you treatment of choice, in that case you have to mark the answer laser excision of granuloma. Remember, you have to remove this granuloma. So treatment of choice still remains laser excision of granuloma with base electrocautery. Okay, so this is the treatment of choice for rhinosporidiosis.